Right, great. So I wanted to thank everyone for showing up today, for agreeing to be on the panel. I think it would probably be best if, real quick, we just went around and got everyone's just a brief background, where you're calling in from.
Sure, I'll start.
Yeah.
That's all right. So I'm Andy Culver. I'm an emergency medicine physician. I work with HCOM in a number of different capacities. So I run the third year emergency medicine course. I also work with third and fourth year students in Cleveland as a clinical assistant dean, and I'm chair of the specialty medicine department for OU-HCOM. Should we popcorn it? I'll popcorn it over to Dr. Rubin.
Okay. I'm Sarah Rubin. I'm a medical anthropologist. I'm in the Department of Social Medicine on the Cleveland campus. And I teach and research racial disparities in maternal and infant health. And I'm the advisor. I have the special privilege of being the advisor of Melissa and Mitchell's Club. And I'll popcorn to Dr. Griggs.
Hello, I'm Jessica Griggs. I'm a family medicine physician. I work part-time at MetroHealth. Also, I'm the associate director for the Resch program on the Cleveland campus. And also, I facilitate clinical skills teaching at HCOM. And I'll popcorn it to Sweeney.
Hello, just to introduce myself, Mitchell. Been nice to send me messages. The one question I have for you, Mitchell, anyone in your family a pediatrician?
I do get asked that a lot. I think it's maybe like,
he was a wonderful,
yeah.
Mountain Yak was a wonderful pediatrician in Cleveland. So here's my background. I'm retired. I practiced for 40 years, 12 years. I was independent in the Westlake, Bay Village, Western Cuyahoga County. And then after 12 years, I joined the clinic and actually was able to stay with my patients because I was placed initially in Westlake, Avon, and then Avon Lake, where I finished up after 25 years. And then I'm retired, and I had been involved in maternal, which is a seasonal shelter for people during the winter months. Usually runs from November till April. And it's people who are what we would call unsheltered or decide not to go to the traditional shelters. And they're an interesting group. So I've been doing for probably about the last 7-8 years, initially when we were at West Side sites, St. Malachy's, and then eventually the Franklin Church. And now we were having a hard time finding a location. We're at a church on the east side, Scion Hill Baptist Church on Kinsman. And then I've been working since actually since we were at Franklin with the DOTS program. So I know Melissa. Hello, Melissa. Haven't you been at DOTS, right? No?
No, I actually haven't. I had signed up, but there was a lot of issues, I think, with getting the site this last year. So it ended up, I just never got to go, but you've probably seen my name.
You look familiar. You look familiar.
Thank you.
So anyhow, that's my and I'm retired right now. I do some primary care and follow-up urgent care online with a company I worked with when I was with the clinic, and so I do that part-time as well.
Cool. I'll go next. My name's Bill Resch. I'm an adult psychiatrist. I've done different subspecialties within psychiatry over the years. Currently, I'm an outpatient psychiatric practice in Columbus, Ohio. I also do some integrated psychiatry with 4 primary care offices. I'm an assistant program director for our residency program. And then this is going on my second year of discipline director for OU-HCOM for psychiatry and the core rotation. I do kind of the seminars for that. So thanks for having me.
All right. All right, great. I think that was everyone for introductions. So for our discussion today, I have some, I guess you could call them guiding questions just to get the conversation started. And I think we wanted to hear a bit about what specific challenges you guys have seen faced by uninsured and underinsured patients, and also how those circumstances might have changed how you approach their care, um, changed how you were able to treat them for their issue. So would anyone like to start in on that? Yeah, go ahead, Dr. Resch.
Yeah, so first, Mitchell, I applaud you and Melissa for starting this committee. It's such an important topic, and I think it's appropriate for all specialties. I'm also glad Dr. Culver and I are on together, because I think of the two specialties probably most often affected by uninsured and underinsured would be his and mine. Dr. Culver is more on the front end, acute crisis side of things, but then mine on the ongoing access, continuity, treatment ongoing with these mental health disorders and substance use disorders. It's so every part of my career has dealt with this for the most part in varying degrees. I would say the biggest thing though is just accessing mental health services, because even with insurance or no insurance, it's just limited resources. So it's really hard to get in the door somewhere that's going to accept that person on a sliding fee scale or variant of that. And then once in the door, we have two arms of therapy that we consider ideal to combine medications and therapy. And oftentimes it's hard to get one or both or either, because just the lack of options for individuals. So we end up kind of adjusting our medications to kind of match that situation. When I was in community mental health, we kind of lived out of our samples closet a lot of times, so it wasn't really your first line treatment option, but it ended up being better than nothing. So that was one way I would do it. I also worked with like the pharmaceutical companies with their patient assistant programs, where you would go through a long application process to prove need to get medications. So that's another way we kind of went about it. On the therapy side, that's also hard because just paying for it, or insurance companies, if you're underinsured or don't have a comprehensive plan, they won't cover therapy, or they'll cover a certain number of sessions, and then you're basically out of luck after 6, 8, 10, whatever the case. And as everyone knows, mental illness tends to be chronic and indefinite. So you end up get this difficult situation where it just becomes more of a concern, and a lot of these disorders get worse with time, and lack of treatment, whether it be psychosis or bipolar spectrum disorder or substance use disorder. There's this like kindling phenomenon, and part of that starts upstream because the lack of access, continuity, and the ability to prevent care. So I think that's kind of in a nutshell where I see it, and how we've kind of altered some of our treatment plans for the reasons you asked.
I'll jump in as to follow up to that. As Dr. Resch mentioned, on the front end of things in the emergency department, we see anything and everything that comes in our doors. I would say it's been my experience, and it's a universal experience for anyone in emergency medicine, any emergency department in the country, pretty much, that the effect of so many of our patients being uninsured, and even more being underinsured, has probably two major effects on the way that I practice. One of the nice things about being an emergency medicine physician is we don't screen people. We take care of everyone who comes in our doors. I like it that way. But the truth of the matter is a lot of people come through our doors because they have nowhere else to go. And so this is one major way that it affects our practice. It's in terms of the folks that show up on our doorstep and the disease burden that those folks carry. As Dr. Resch pointed out, this is a population of people who are unable to get access to good preventive care, continuity of care, primary care services. And so oftentimes their chronic diseases go untreated or undertreated to the point that they end up in the emergency department because of a complication from their condition, from their chronically untreated conditions like hypertension, diabetes, heart disease. And they come into the ED when they're having the heart attack or the stroke or, diabetic complications, which could have been prevented had they had better access to care. So we're seeing a lot of them in the emergency department because of that, and also because they just don't have anywhere else to go, even for their minor care, for their primary care, and certainly for their acute care. The other way that I would say it affects my day-to-day care in the emergency department is in terms of once I've stabilized someone's acute condition, well, we have a decision to make whether we admit them to the hospital or whether we discharge the patient home. When we discharge patients, we need to always assure that they can not only get their medication, get their therapeutics, whatever that might be for their complaint that they presented with and their diagnosis, but also that they could get good follow-up from the emergency department. We put out fires in the ED. That's all we do. We take care of that acute problem, but then we rely on the rest of the healthcare system to take it over, to take the baton handoff from there and manage that patient's condition when they leave the emergency department. If I don't have a place or a provider to send that patient to, then it's really hard to keep them from bouncing right back to the emergency department again, or going to another facility, or just generally getting sicker. And so that's a major challenge. Sometimes, even if the patient does have insurance, if they have Medicaid, for example, many providers aren't accepting that. And so getting the patient a follow-up physician can be very challenging. If it's a condition that doesn't require a physician, like dental emergencies, we see all the time in the emergency department. Good luck getting anyone to a dentist in follow-up if they don't have insurance or if they're on Medicaid. We give them a list. Basically, what happens is we give them a list of providers and say, here, call around to some of these dentists. Hopefully, someone will be willing to see you. Those challenges from the time that they are discharged until the time that they can hopefully get medical care in some other point in the healthcare system, there are a lot of barriers to go from point A to point B for those folks. And so this affects the health of our population and certainly affects the day-to-day care that we provide or that we need to provide in the emergency department.
I'm going to step in here, and I'm going to give the 4,000 foot initially and then come down. I teach at CASE. I teach small groups. I'm a facilitator. And when the ACA when we were talking about, and Mitchell had, the group is, universal health care, there was a whole process that we did to help the students at that point, and generally look at the politics about why it was important to make the changes that the ACA made. And luckily it got passed. And what we've seen for the last, since it was passed, is chipping away at the ACA. This next step, which is reduction of the Medicare population, 80% of Medicaid, Medicaid pop, 80% are already working someplace. But now, so you have to make sure you keep on showing them. And now they're going to make it so you have to do that every 6 months, with the whole idea is that people have a hard time doing it once a year. And we get to 6 months, we're going to lose some people off of Medicaid. We're not going to have to pay for them on Medicaid. And so what Dr. Resch and Dr. Culver said is just going to get worse. You probably have read the statistics, with what they passed. There are going to be, I don't know, I've heard 13 to 20 million people. Kind of that 40 million that we got covered, it's going to be cut in half. And Medicaid's going to be a huge part of it. Now the more close-up view is my care for the unhoused or the unsheltered that we do every winter. It's interesting. Most of those people have at one point or another had Medicaid cards, and have had insurance. And you talk to them when we're doing our assessment, they've either seen the clinic or Metro or UH. But the real issue becomes are they up to date on their enrollment? And many times they are not up to date on their enrollment. And so both the traditional shelters and what we try to do is get that moved along. Otherwise, they wind up with Dr. Culver. They go to the ER for all their care. And what I was amazed at with my group of people, it was like 35 this last season, is how many of them have primary care doctors, or at least at one point had seen a primary care doctor, but how many also do not have their insurance any longer. And so it's a real crisis. We've had this crisis. We kind of fixed some of it with the ACA and even working people that can go on to the, I'm forgetting its name, the online service, the government program. Even that's going to be starting to be restricted. So even that's going to get tougher for regular practices. So this is a tough time. This is a tough time. What I saw 8 years ago, where we were able to move along and not be universal care, but as a country move along that movement so that we would not look like the worst healthcare system in the world. And now it's being torn apart. I hate to be pessimistic, or I'm not being pessimistic. I'm being realistic, and it's going to be, both for your educators, it's going to be an interesting time. For your students, you're going to be coming out where it's going to go back where it was 10 years ago. 10 years ago, the clinic never took Medicaid. Okay. The clinic, I was in Lorain County, and I couldn't see some Medicaid patients. About 10 years ago, they started taking it because Medicaid became at least they would get patients in the door. And so that access at the clinic opened up. As you saw recently, they tried to get everybody to pay their co-payments up front, and otherwise we won't see you. So that's the kind of stuff that unfortunately we're in right now.
And just to take it a step, I'm sorry, Dr. Griggs, briefly, just to take it a step further, what Dr. Sweeney has said, we was talking about, with the One Big Beautiful Bill Act passed, 10 to 20 million people are going to be dropped off the Medicaid roster, and those folks are going to suffer in the ways that we've talked about. But it goes beyond that. You've probably read and heard about rural hospitals. I work at a rural emergency department. Some of those hospitals are not going to be able to make ends meet anymore with the changes in their Medicaid reimbursement. And these are critical access areas. These are hospitals that exist in places that their populations have no access to acute care anywhere else in the vicinity. So these are folks that are going to not only lose their own insurance, but they're going to lose their ability to get acute care anywhere near them. And so there will certainly be deaths. There will be catastrophic outcomes. There's just no way of looking at it any other way. So I agree. I think I don't like to be pessimistic either, but this is realism we're discussing here now. This is the reality of where things are and where they're headed, and why it is so important for students, for folks, and all of us, but certainly for you and your generation of up and coming healthcare professionals to help lead the charge for change, to educate yourselves and to advocate and to work on public policy and to work on trying to find actual solutions to this problem. I think I talk about my generation and all previous generations have done a very poor job of creating a sustainable system. Our system is not sustainable. And in many ways, it's not a healthcare system at all. It's a collection of competing financial interests. And, we've got to do better. Even right now, even before these changes take effect, when we look at our health outcomes, they're bad. I mean, compared to every other industrialized nation in the world, our health outcomes virtually across the board are right at or near the very bottom of the list. We're pretty good with research. We're pretty good with, with advancement of knowledge. But as far as the actual provision of healthcare to our population, the data's there. It's not good.
Looks like Dr. Rubin and then Dr. Griggs both have
Dr.
your
Griggs, you
hand
go
raised.
first. You're actually on the panel, not me.
Yes, I was going to answer the question in regards to, social determinants of health that are most pressing for me. And as a primary care physician, I could say it's all the above. I've seen it all from food insecurity, housing issues, insurance issues, access to primary care, access to medications. All the above. And actually, I was just thinking what Dr. Sweeney said. I used to practice in Lorain, Ohio, Lorain County Health and Dentistry for 10 years before I started at MetroHealth. And yes, Lorain County is different, but Lorain was most of the physicians just accepted private insurance up until the Affordable Care Act passed, which allowed more families, especially if you're like what do you call it, the working poor, where it expanded your criteria for
Right.
Medicaid. Yes. And yes, so I was at a clinic, family FQHC, that that's all we saw was self-pay and Medicaid, and it was rough. But once the Affordable Care Act came into play, that helped tremendously. But today, I would say today in the office, mostly it's housing. I would say the most dominant is housing issues. Whether or not the person is homeless, the homeless shelters are are filling up. And then some people don't want to go to the homeless shelters just for the stigma. And then also just got to be careful of some of the crime that goes on in those type of places. I see predominantly elderly population, and a lot of them are looking for new housing, but the list, especially in Cuyahoga County, is long. Mainly looking for new housing because the housing that they have is not adequate. I had one patient that her apartment complex was without water for like 3 months, and how that happens. I don't know. There's been heating issues, and you would think, especially with our elderly population, they've lived X amount of time, that, how can we treat them in this manner? I've had a couple of patients in the Cleveland area that they lived adjacent to victims of crime. So one found someone stabbed to death in the unit next to them. Another one, a unit below them, a young guy was murdered, pretty much. So just try my best to work with what I can with Metropolitan Housing, HUD, social workers to get these people adequate housing. And yeah, it's frustrating, especially in primary care end. Dr. Rubin, you had a question?
And then
No, it's
I just
okay. I want
wanted
to hear.
to
I want to
I
hear what
just wanted
Mitchell
to
has to say next.
interject real quick.
Oh, sure.
Because I know we're kind of allowing everyone to talk right now, but if you have any specific questions and you don't want to interrupt, you can go ahead and just throw those into the chat. I think that would be great, and then we could kind of swing back around and make sure we get all those answered. So Dr. Rubin, you could go ahead now.
Okay. I decided that I wasn't going to say my thing until later, so you can go ahead. Or I'll ask it in the chat so I'm less like. Thanks.
You're being photobombed, Sarah.
At least he's wearing clothes. They like to be nude when I'm in meetings.
Oh, wow. Yeah. So
Eventually they'll grow out of it, but.
all right. Oh, that's funny.
He
Um,
just said, "I'll never grow out of it."
but
I
I
mean,
think like especially with what Dr. Culver was talking about with the cuts to Medicaid and um, what Dr. Sweeney was talking about, that's what really motivated me to start this club and to hold this panel. I see that as being a really big issue, and we kind of talked about it a little bit, like how um, kind of like baseline how you would expect it to affect your practice, affect access to care. Did anyone have anything else to add to that?
One thing I will add. So what is the name of your group again?
It's Students for a National Health Program.
Okay. So going back to the 4,000 foot, when ACA there was a fight about ACA, medical students were really important. And so that, where we're at now, we've kind of painted a tough picture for people in healthcare. You can have some impact. And hopefully you'll see places where you can. I know that at the clinic we had some students that were very active and helping to push at least the ACA. And so don't be pessimistic about what you can possibly help moving us forward as a country.
And then, Melissa, did you have something to say?
Yeah, kind of just to that point. I mean, I think that there's a lot of us, I mean, especially, Mitch and I and Sean realizing how important these things are, obviously, especially now. There doesn't necessarily seem to be the support at all levels, whether that be for fear of retaliation, for fear of we don't know how things are changing. Unfortunately, these talks aren't necessarily happening in the manner I wish they were, within our medical school community. So I guess my question to your point is, what were those avenues that you felt helped those students be heard? And how do you think that we could adapt that, especially in today's environment with kind of the pushback that people are seeing and organizations are seeing?
What I remember is that a number of them, it wasn't the school that did it, pushed. A number of them joined more national organizations. And so the one thing I would say for you, whether statewide or national wise, there's organizations that are pushing for this all over the country and have been for years in terms of a one payer system. And I think, if you have the interest in doing that, to have some impact connecting with them. And what happens a lot of times is we're going to have a medical student, not protest, but a march or talks or whatever, but on a national level. So that's what I would tell you. And that's the students I saw back when we were grappling with this. That's where they had a group, I think, within the school, but they also reached out to other organizations.
Yeah, and I agree with Dr. Sweeney on that. That one of the challenges for schools is that schools are constrained when it comes to wading into political, social conversations because of our current social climate, our economic climate, and in Ohio, this is not just on the federal level, but in the state level as well. We as at HCOM, we're a state-funded school, so we have certain constraints, but as a student and as a student organization, you don't have those kinds of constraints. I agree. There is power in numbers, and to the extent that you can join with other student organizations, you have a lot of power. Your voice has a lot of power. And on that note, I was going to ask a question for you, Melissa Mitchell. Is this student organization, a chapter organization of a national organization, or is this a fresh start for us, for you?
It is a chapter of a national org,
Good.
yeah. Mhm.
Good. And does that organization have its own leadership structure, meetings, et cetera, that you guys can become a part of potentially?
It does. They have at the statewide level in Ohio with all the other medical schools, and then they have a national chapter too. And they're partnered with, we're students for a national health program, and it's actually like a ancillary org to physicians for a national health program. So I think when you get a little bit like higher up, there's more even interaction with like physicians, professionals. I think a lot of residents are involved with it.
Yeah, that's great. I applaud what you're doing very much.
And then did Dr. Resch have something to say? Or?
Yeah, just back to
Yeah.
Melissa's great question. Like, this is seems so daunting. Like, where do you even start, right? I mean, it's just a monster of a problem. So, you ever heard that expression, all politics are local, Melissa? So, I think sometimes where to start would be like a professional organization. Mitchell shared with me he's interested in psychiatry. So, we have a pretty active chapter of organized psychiatry in Ohio, and they have a government relations committee of which medical students can get involved in and sit in on those meetings, and then they can work with other psychiatrists or whatever specialty you like to advocate for certain, legislations, bills that are in effect in the current General Assembly. And we've actually had decent success at various times in issues of access and equity and things. So that would be a good place to start. Also I would say the OOA, Ohio Osteopathic Association, the AOA, they all have advocacy days at the courthouses and the Capitol buildings and things. And the last time I went to Advocacy Day in the spring, we were there to kind of campaign for what we call adequate panels of insurance companies. So they were treating as they should with, on a federal and state level, like parity, treat mental health on par, in line with physical health, which doesn't happen in reality. So we were campaigning for that. And ironically, I was running into all these ER doctors also there same day for advocating. And we asked them what they were campaigning on. They had their own issue of when they were seeing patients. I think they said they were uninsured. They would see them in crisis, like with a life-threatening condition, and somehow they get downcoded to where it was no longer life-threatening, and the insurance company wouldn't cover it at that point. So we crossed paths with ER docs the same day. So I would try to get in with a professional organization at that ground level, to go up that way. And then I think it builds from there, but you got to start somewhere, right? And I think that's where you might want to consider starting and then kind of growing it from there, because if you try to go the other way, it might be a little bit harder. So, whoops, sorry, went the other way.
And I could see, I think I understand what you mean, because it has been, I mean, even with an organization that's a chapter of a national org, it has been, I don't know, like kind of difficult to get our footing and decide like what action should we be taking, who should we be talking to, and yeah, I mean, I feel like something like you mentioned, kind of be more aware of things that are happening, network more.
Yeah,
I definitely understand that.
and obviously I know what I know through psychiatry. We actually have a really robust government relations committee. We actually hire a lobbyist, and they're kind of giving us information, and they kind of facilitate a lot of the discussions, and they know the players and the movers and shakers, and it's so much more effective to have a good lobbyist. She also works with the Ohio State Medical Association, so it all kind of is integrating. But I think that would be a good place to consider starting.
Okay, yeah, perfect. I'll definitely email you after the session and we can talk about it more. It looks like Elena has a question.
Yes, I wanted to ask a question, but it's a little bit, I know you were talking about the organizations and the future of it. I was just kind of curious about, because I know America in the past, in the early 20th century, they wanted to do like a government-run medical insurance for everyone, kind of similar to what it's happening in Europe. And I know the AMA did a good lobbying against it because it was seen also because of the cultural background at the time with the World War II going on and with um, the socialism. So they advocated against that. Is there something that we can do in the future so that we can have some sort of um, either like healthcare for all so that everyone can be um, insured at one point, or at least have, let's say, 5% covered by the government, through taxpayer. If you pay taxes to the government, you get also, let's say, like 5% insurance coverage or something like that. I hope if that makes sense.
I think maybe Dr. Sweeney was talking a lot about when the ACA got passed, and uh, he probably knows a lot more about this than I do. But with the ACA, when it was proposed, included what was called a public option. And do you have anything to say about that, Dr. Sweeney?
Go ahead. I mean, I'm not sure what
Yeah.
what your point is. Go ahead about the public option.
Yeah. I mean, it would have been, my understanding of a public option would have been that it would have been like a Medicaid type buy-in that anyone could enroll in, and it would have been heavily subsidized, and it would have been more, more affordable than standard insurance. And I guess if we're talking about like how are we going to get to full coverage, that's often the idea that I've encountered, that you do a public option, and that's probably the next step towards that. And down the line, you could maybe repurpose that to cover everyone.
Well, yeah, and the reason it didn't get in there is there was lots of lobbying from the insurance companies, particularly against that. And then and to answer, was it Elaine that? Yes, Elaine. There were a number of physician groups that came out in favor of a number of the avenues of the ACA. So, and I can't remember, was the AMA may have even come out when it got tweaked to the point where it's not quite as robust a healthcare system as anyone wanted. But they may have come out in favor of the ACA. I'd have to go back and look at that. So, and the reason I think they did was they know the statistics, they know how bad our healthcare system is, and they hear it from everybody. And so that movement compared to where it was in the 40s and 30s, the AMA is much more, I know even my time when I was in the 70s and 80s is much more open to this possibility. They may not be open to a one-payer system, but they know that the system we have is not working and it needs to be further changed.
And I mean, there are a lot of opinions on this. It's not easy to move the needle in healthcare in general. Our government, our politicians have tried making changes. I mean, they've tried to take this on for decades, and it tends to be a lot harder than anyone thinks it's going to be. And my feeling about most politicians is they don't have any idea how the health system even works, much less what can be done to fix all of these problems. And so what is done sometimes is Band-Aids get thrown on, but fundamentally to improve our healthcare system, and this is just my speaking from personal opinion. This is not the college's, opinion necessarily. I'm just sharing my own thoughts. But I think the only way that we really truly move the needle on this is to fundamentally change the way our healthcare system, our health is funded, health coverage is funded, and that means something at the level of a national health plan or universal coverage of some sort. How we get there is, I don't have an answer. How we get everyone to agree to do that, I don't have an answer to that either. But what I will say is that I think there is more appetite for these discussions. As Dr. Sweeney mentioned, the AMA might be more willing now than they were a few decades ago. I think especially now, after passage of the OEBBA and the what we see happening to healthcare and access, specifically to access, loss of access, coupled with our poor health outcomes in comparison to the rest of the industrialized world, I think there is more appetite to start thinking about big solutions than there probably has been for quite a long time. And this is where these types of discussions, this type of student organization, these types of efforts come into play.
Thank you for
One
your
quick
answer.
follow-up on that would be that the dissatisfaction with the health, we've been talking about Medicare, Medicaid, and unfortunately, that population doesn't have a lot of political power, okay? So they can't, but in this country now, and you probably know it in your family, very many middle-class people are not happy with the insurance we have, and how it's managed. And that's a huge population that not only may feel supportive of the Medicaid population and feel that we need to do more, but they are not unhappy. They're unhappy with the healthcare they're receiving, and that's a big that's an area that can be not manipulated, but tied into, besides just for the people at the lower end. The middle class in this country are not happy with their healthcare. Whether it's, they just aren't. They can't get in. They don't see who they want to see. They can't get referrals. They wind up, getting something and then it gets denied, and that's the whole denial system is a mess. So there's a lot of not happy people out there with our healthcare system. We just have to mobilize.
It looks like Dr. Resch had something to say, and then Dr. Griggs. And then after that, I wanted to kind of open everything up to discussion from our audience.
You're muted.
Oh, I think you're muted.
Yeah, sorry. I was just going to make a little bit of a kind of an observation and shared experience in listening to everybody tonight. I think it's easy to get kind of pessimistic about this, regarding the current environment and the lack of success so far. So I was thinking, like, preparing for this, when I was in community mental health, I was actually on the National Health Service Corps in an underserved 2 areas of the state: Benton County, one of the poorest counties in Ohio, and Hocking, another poor. So I was doing the psychiatry. I was the only psychiatrist really in those counties, and dealing a lot with uninsured and underinsured. And that's where I was living out of the samples closet, patient assisted programs. So I did that for about 3 years, found it really gratifying. But I went to that very challenging system, and I went right into the VA. And I don't know how many people has worked in the VA, but that's the closest thing I can say in my career that I've kind of worked with universal healthcare, because every patient you come into contact with is covered. And with that, I saw the benefits of it. And, it's encouraging and kind of aspirational, but the patient care was pretty good. As a clinician, I was so thankful to have the resources that we did. That's another area of healthcare where I think they get the fact that mental health and substance use disorders are really important to treat, and it's kind of online or on par with physical conditions. So it was a great place to work. I saw great outcomes. People were not, always wanting to say, get them out the door. They were just, I didn't have step therapy to go through. I'd be able to refer people to counseling of all kinds, marriage and family counseling, individual PTS counseling, whatever it is, it was available. And I lived in that system for 6.5 years, coming from, underserved Appalachia. And it was just so stark. And I saw the differences and the benefits, and I lived it. And like you said, Mitchell, this kind of current healthcare system is not cheap. It's very expensive to just be so crisis oriented and not really on the preventative or maintenance side. In fact, the VA, as much as they do and the resources, it's one of the cheaper, more affordable healthcare systems in the country, if not the world, and it's the biggest one. So I think it can be done. So I as much as we want to fight being pessimistic, I want to be optimistic that I've seen it work. I've lived it. I've seen the benefits of it. And it's so gratifying as a physician to have those resources and not have to worry about, well, how am I going to do this? And find all these creative ways. And it was just there. So that would be my kind of observation and aspirational thoughts on why this is an important club and, endeavor for all of you future physician leaders of, America to consider. So that was just, I wanted to throw that out because I was thinking about that, how different it was. And I even would tell people like, oh, it's going to be hard to leave the VA, go back to the real world. And I did. And now I'm in the real world for 10 years and it's the same stuff over and over. It doesn't seem to change a whole lot, not drastically. So that's all I wanted to kind of say about that. So thanks.
I think it's funny that you refer to this as the real world. The VA is fantasy land, but it's real too. And like Dr. Resch says, it works and it's here on our soil.
I think what's funny about bringing up the VA, the exec board for this club includes Melissa and includes Sean, and they both go to the VA.
So
no
kidding, for personal healthcare.
So I might,
awesome.
I don't know, shine a light on their motivation for type of cause. But did you want to say anything about that, Melissa? Or
I was going to completely agree. I mean, I was a corpsman in the Navy for 7 years, so I worked in active duty medicine and then got out, and I'm now part of the VA. And I think it has me pulling my hair out even more because I can see that it works. I can see that there are options. I can see that it can flow really, really well. I know how to do all of it. And so I'm in these civilian healthcare systems and I'm just, what is happening? What's going on? Why can we not fix this? And it's so just incredibly frustrating. So to hear the backup is nice. And I completely agree. It's absolutely possible. It just, unfortunately, there seems to be a lot of stops coming up with money and everything. So.
Yeah, I'll say,
sorry
I
to get us.
apologize. So.
Oh, go ahead, Sean.
So, Mitch, this is Sean. So, I was going to say, I was a naval officer before, so on active duty, it was amazing to have everything from healthcare where, if anything happened, you knew you were going to be covered. And I had friends that, healthy individuals, cancer diagnosis, everything was all managed, even if they had to refer out. But on the VA side, I then went and afterwards I ended up working at Cardinal Health, and a lot of the pharmaceutical distributors and stuff, actually, it was hilarious. They hated working with the VA because the VA, because of their size, because of their scope, they could negotiate down the rates so low. So the margins were extremely low for these companies. And on my side, now going to become a physician, that's great. These large organizations having a large network, they had the two sides of it. One, they have all the shared data across it, so they can do a lot more extrapolation of data, a lot more extensive research, a lot more shared clinical trial information. So, and they have the access to the funding for it, and then they can negotiate down the costs down low to where they're able to provide that care really within an affordable scope. So, I saw the benefits from that side, and but yeah, it seems like it's something that should be possible and attainable. It's just there's a lot of roadblocks, and some of those are, the companies and such that I also used to work at have plenty of lobbyists and people that are actively working on that part.
And then, Dr. Griggs, I apologize for getting us sidetracked there.
Oh, that's okay. Good conversation. But I was just gonna say that, I don't know what the answer is. I think about when I think about universal health care, I think about Canada in particular. I've met residents and physicians, Canadian physicians, and actually, I don't know, as far as like your weight, like let's say if you need knee replacement surgery, your weight is, you have a long wait time compared to the US. So I think it's just, I guess there's plus and minuses. There's no really clear answer, but I was just thinking about different healthcare models. There's a center, if you're familiar with Oak Street Health, they have a value-based model, and not the fee-for-service model. So I think, I believe they only see Medicare patients, and Medicare pays them a certain fee for the patient, or for you to take so many patients, and the patient can come as many times as they want to. They get longer, they get more focused care, and and the physicians get paid based on, whether or not, they're meeting their healthcare gaps, whether they're getting their flu shot, colonoscopy, I'm trying to think, mammogram, bone density tests. So, that's one. Just learned a little bit about Oak Street Health, but that's one model that I think would be excellent, because it's just so staggering how we as a developed nation has the poorest health outcomes. I just read in my CNN report this morning that Mississippi has an infant mortality health crisis right now. So it's like 9.7 per thousand infants died pretty much in 2024, which is significantly increased. And you would think in United States that, that shouldn't happen, but it has. And hopefully that's an eye opener. That was a headline on CNN this morning. So hopefully that's an eye opener for whoever makes the laws as far as, in public health terms.
Yeah, we can only hope, right? That sounds terrible. Wow. And that's interesting. I've heard a bit about Oak Street. That is interesting to me. It sounds like they do like a good service for the
For the
community.
elderly.
So
Yeah, for elderly and or Medicare patient, elderly and disabled. Yes. This value-based model. Yep.
Mhm. Well, all right, guys. We have about 3 minutes left, and I want to make sure I'm respecting everyone's time. So we might have time for one more question or comment. Did anyone in the audience want to ask the panel anything before we end? Don't be shy. Come on. Okay. Well, thank you guys for agreeing to do this panel. A lot of great information. I think we had a nice discussion. So I hope everyone has a nice night, and everyone take care, okay?
Thank you.
Thank you.
Thank you so much, everyone. This was great.
Thanks, everyone.
Yeah,
Yeah,
good discussion.
thank you.
It's good starting point, y'all. So keep up the good work and keep the faith.
Keep it going. Yep.
I agree. All right. Take care.